Chapter 27, the female system. Again, go through your bio. We won't be covering bio, nor will we be testing on bio. Again, please be familiar with your location, just because it helps you with your diagnosis. And if you've got pain, you can kind of try and figure it out. Some of this stuff we did go through already, so we'll just do it really quick. Age or start of menses. Again, totally independent, although it's getting younger and younger. Ages 8 to, I don't know, up to 16. If we talk about pregnancy, you can follow those pregnancy topics that we went through and the presumptive signs of pregnancy, like Goodwell's and Chadwick's and Hager-Stein, changes to the uterus, the mucus probe, we talked about the protection, and vaginal secretions are normal. And then if you talk about older ladies, so a decrease in hormones causes the onset of menopause. The uterus obviously gets smaller. It's not a functional or a needed organ. And fragile cervix just because of the loss of estrogen. So if we talk about cultural and social considerations, it is illegal in Canada to do a female circumcision, even though that is culturally accepted in some parts of the world. STIs or any kind of sexually transmitted diseases need to be investigated and dealt with appropriately to not cause problems with fertility. So discharge, pain, and increasing risk for AIDS is usually part of our teaching. And a lot of females are prone to UTIs, very small or short urethra, which is, about 4 or 5 inches, which means it's really easy to transmit infections. So sometimes you need to get a menstrual history or last menstrual, obstetrical history if that's pertinent for your chief complaint, the onset of menopause and when that started, because after the onset of menopause and the cessation of menses, there shouldn't be any vaginal bleeding once that has been completed. If not, it needs to be investigated. Any urinary symptoms, especially for your geriatric, and any vaginal discharge, we want a coac. Past history, usually sexual activity only if that's pertinent to our chief. What kind of contraceptive use, knowing that, right, condoms aren't all that fail-proof, neither is the pill if you don't take it at the same time every day. STIs, again, and STI reduction is just something we're going to talk about quickly. Additional history questions, so infants and children, if there's urination problems, if there's any kind of chromosomal or genital issues, and then molestation we talked about with the male, so we don't re-traumatize people by asking questions. We just look at the physical, deal with our mental aspects of our patients, and then the story and the deposition is left for lawyers and the police. So pre-adolescence and adolescence, if it's pertinent, the onset of puberty, or more pertinent is the onset of menstruation, any kind of information, any kind of disease process going on with that pre-adolescent or adolescent, and immunization. And then again, the same thing for signs and symptoms of any kind of abuse. Older women, we kind of talked about this. There shouldn't be bleeding after the cessation of menses. If there's any vaginal issues, like a prolapse, any urinary incontinence, stress incontinence, or issues with sexuality. Promoting health, I'm just going to let you do your own research on HPV, so you can read this and the risk factors, and I think it's only good for 3 to 4 types of HPV, when I think there's many different types of cancer, or many different types of that human papillomavirus. Again, I'm not going to go through this because I think this is propaganda. We're not going to do a physical exam, but this is what happens or this is the position for a female vaginal exam. You might be asked to do this and emerge as a witness or bystander, which is perfectly pertinent. So this is the lithotomy position. Easy access to the vagina and all the structures. And ladies can have a mirror to see, so like in childbirth you can watch. External genitalia, only if this is our chief complaint, but please know the external structures because it's really important when you go to catheterize, which is in your scope. So I always tell people to kind of make sure that you know the external structures, the labia majora and the labia minor, so we can try and find the urethral opening. So that means like a, I don't know, a guess in between. So it's clitoris and vagina and your urethra is in the middle. So make sure that you know the difference and where to find that. The vaginal opening, the perineum, and the anus. So special considerations for exact advanced practice. So we don't do internal exams. It's not in our scope, but this is pictures of the cervix and the os and problems that that can accompany that organ. Okay. And so you can see the different issues again, just so you can appreciate cysts versus infection versus one from a lady who's never had a baby and one that has had childbirth. A vaginal childbirth. So during exams or and that can be in a MERGE or a doctor's office, they do usually do pap smears and look for STIs. It goes straight to the laboratories, prepared on a slide, and you might have to assist with that. Again, maybe just as an observer or to hand or just to be in the room. So again, just more extra. We're not going to do any exams of the cervix, the uterus, or the recto-vaginal examination, nor the vaginal wall. Developmental considerations. So kids, again, just an external look. Might be diaper rash, right? It might be infection. It might be a yeast infection. Adolescents, again, we don't or would never re-traumatize to visualize unless that's our trauma situation. Pregnancy or pregnant women's, you might see varicose veins. Again, we're not going to do an internal to see Chadwick's or Hager's. And older women, again, that vaginal exam is left for specialists. We would never do that. Here's some sample charting for you. Again, no negative charting. I'll just let you go on. So abnormal findings, and please just follow along in your books because the pictures are very vivid again. Your book goes through and gives you quite a few. So remember, no internals, no anals, and we'll just get into the abnormalities of this, okay? So the pelvic musculature, so you could have a cystocele, a retrocele, or a uterine prolapse, and I'll let you read what that is. It just means because of childbirth, there's been a change in the structure and function. So differences or abnormalities with the cervix, so that bluish cervix or cyanosis, erosion, HPV or cancer. You could have polyps, DES, and or carcinoma, which is what they're looking for and trying to avoid with that HPV. Vulvovaginal inflammations, and this is where you've kind of got your pictures here. So your atropic vaginitis is obviously an inflammation of the vagina. Candida or candidiasis is just a yeast infection. A trichomoniasis, I believe, is an infection. A bacterial vaginosis, so it's a bacterial infection. Chlamydia is an STI, and so is gonorrhea. So conditions of uterine enlargement, so usually it's pregnancy or a tumor. It could be carcinoma or profound endometriosis. Any kind of abdominal, more dealing with ovaries, so it could be polycystic ovary disease, it could be ovarian cancer, it could be an ectopic pregnancy, or that pelvic inflammatory disease, a PID. So we always try and rule out the worst first, and that is ovarian cancer, because that spreads really quickly and has a really high incidence of short death. It's kind of like pancreatic cancer. So abnormalities with the pediatric genitalia, so if they're born, there's lots of hormones from mom, and sometimes the genitalia can be really swollen or ambiguous, or sometimes just chromosomal abnormalities, and sometimes you can get an infection. There's a history question for you, and that is it.